right, everybody. Why don't we get set for our last lecture of the day, and we saved our best for last. My co-chair, Kristin Wingfield. I've already gave you a bit of intro, but just to remind you guys, she was a diver on the Canadian national team. She worked with the first Cirque du Soleil that was in Las Vegas, Mystère, and she did that for several years. And then she's got her medical degree at UBC and then came to Stanford for fellowship. So, I can't think of anyone better to give this talk because she's definitely got the experience, and I think we're in for a great treat for this last talk on dance medicine. So thanks, Kristin.
Thank you for that nice introduction, Dr. Luke, and thanks for all your help running the course. And to the audience, thanks for sticking around for the last talk of the day and some of the other lectures. So I have nothing to disclose. I am going to talk a little bit about dance medicine. That's a slide about me, but we'll move on. I am currently the physician for the San Francisco Ballet and work with them. And I have worked with multiple dance and performing companies in San Francisco over the years, from Hamilton to many of the ACT shows, the San Francisco Ballet School, some local schools in Marin, and I still see many dancers in my practice. So today we're going to talk a little bit about the hypermobility associated with dance and the dancer and how it's the art selects for those characteristics and what that does to injury risk and how we treat injuries that are related to hypermobility in a dancer. We will look at alignment, and we'll talk a little bit about the basics of dance so you know what you're looking at, and how that predisposes to injuries and how injuries arise from that alignment. We'll talk about injury patterns of dance injuries based on some of the literature, and then what I see, and then a little bit about stress fractures. There's a link to this. I don't have it set up for now, but it just shows a little bit of the ballet's, San Francisco Ballet's programs for the year, and it gives you a little idea, as do my photos in this talk, of the hypermobility and the range of motion associated with dance. So we'll start by speaking a little bit about hypermobility or excess motion. And so there are many things that contribute to excess motion. One being bone shape, and so if we think about that mainly in the hip, as Dr. Wong spoke about a little bit earlier, there are just slight anatomic differences in the shape of the hip joint. And dysplasia, as you may remember from training, when in pediatric population we check for hip dysplasia when kids are young, they have a very shallow socket to the point where the hip can dislocate. And in ballet dancers, we find many have some mild dysplasia. So the socket isn't fully formed, it's slightly dysplastic or slightly shallow, and that allows for a lot more range of motion of the leg to get high and give them that range of motion that ballet selects for. Collagen is the elastic properties in the tissue. Many dancers, and there's a variation on normal, have very elastic tissue. I do as well. Soft tissue that's very flexible, skin tissue and ligaments and muscle tissue that stretches. And so that's just often a genetic thing. As you know, some people are tight, some people are flexible. And dance, you can't dance and be tight. You have to give it your leg up here. Muscle weakness and wasting contributes to hypermobility, obviously. When dancers are hypermobile, they have to be a little extra strong to control the joint motion that they have, and particularly under impact. And so if we see weakness or wasting, then we know that they're going to be at higher risk for injury, and often we see that with pain, and so we address that in the rehab and how we get them back so they can control their hypermobility. Proprioception may or may not be impaired with hypermobility because, again, your joint's not always in the perfect position. It may be going past its neutral, and so the proprioceptive feedback may be slightly different, particularly in ankles, for example, after an ankle sprain. If you have some ligamentous laxity or you've stretched those ligaments out and they scar in, but they're not quite as tight as they were pre-injury, your balance can be a little off when your foot shifts around as well. We can train that, and we can help manage that with training and extra practice and retraining the systems. And as Dr. Edwards alluded to earlier today in her talk about female athlete and ACL injuries, we think there are probably some hormonal variations in the injury risk and in the flexibility of ligaments. Dr. Edwards mentioned that ACLs have estrogen receptors and female ACLs have different hormone receptors than males. And so we do see some hormonal variability in flexibility, which may be partly why females tend to be, not always can be more flexible than males. So depending on the criteria used, the epidemiologic studies suggest that the hypermobility seen in dancers can be as high as 44%, especially in students. Dr. de Borja just was explaining when kids are young, they are very flexible, their tissues are looser, and even more so in the dancers. You can see extreme flexibility as their joints haven't fully developed and their tissues haven't tightened up and they're still growing and not as strong. Some of the young dancers can be extremely flexible. The Baton score is something used to address hypermobility, and it's a grading system that I won't go into. You can look it up, but there's different ways to grade hypermobility. And some studies suggest that maybe this is not an appropriate measure of hypermobility because the dance population is so far ahead of the normal population in terms of hypermobility. So it's hard to really correlate and categorize and study, what level of hypermobility causes injury in that population because they're so far extreme. So in ballet in particular, it selects for people with excessive hip external rotation. It's called turnout. Any of you who've seen some ballet know that the lines are nicer when the hips are turned out and you get a nice hyperextension through the elbow and the ankle, which we'll show pictures of. And so ballet involves a lot of turnout to get this beautiful line. It's all a visual art. And so it selects for these people with excessive hip external rotation, and they do things like this and spend hours in these positions to stretch out the anterior hip capsule and get more external rotation. And then, as we mentioned, many dancers have mild hip dysplasia. We keep talking about, I work at the San Francisco Ballet once a week. We should do a study and x-ray everyone coming in and look for hip dysplasia and document it all. And, that's a little troublesome because you're giving everybody x-ray, but I bet a high percentage of those elite dancers have some hip dysplasia. And again, we just manage it with strength and injury surveillance and rehabilitation. And if needed, we address it more with an injury. So as turnout increases, you can imagine the stresses on the front of the hip increase. So the back capsules get tight, the hip shifts forward a little, and you get more stress on the anterior capsule, the anterior labrum, and also the hip flexors that come down the front of the hip. The hip is like the shoulder, so I'm using my shoulder to show you. We see a lot of hip flexor pain, and we try to differentiate between capsular pain, internal joint pain versus hip flexor tightness and irritation. We also work on strengthening the posterior hip, the glutes, and stretching out the capsules to try to keep their hips balanced. And then in dancers, it's very common to see internal rotation at 0. They don't actually internally rotate much. Often they really externally rotate, and they never work their internal rotation. So they're very imbalanced. So these are some positions in ballet, and you can see how the turnout comes from the hips so that the knees are still aligned over the toes. So in first position, the heels are together. In second position, the feet are apart. Fourth position, it's crossed, but the leg is in front. I think I have fifth. And here we have fifth position, the feet are right across, and this is probably the toughest position. There's a lot of torque on the knee and the ankle joint. And you see these two views from the side that show the hyperextended knees, the genu recurvatum, that the ballet selects for. So we like to see these long hyperextended lines. So if you look at these pictures, especially the side views, you see the torque on that ankle joint. And if the dancers aren't strong in their hips and they can't turn out from the hips, they're going to roll in and twist from their knees. So you can see how they would have anterior knee pain if the knee isn't tracking well. And you can see the stress put on the medial structures in the ankle. And particularly their landing jumps in this position, and if they're fatigued and weak, they can roll in and sustain injuries. This is just a nice picture showing a normal dancer with their hyperextended elbows, wrists, and this shows a nice picture of the foot position in dance, which is called winging, where the foot is deviated externally, so towards the baby toe. So you're activating your perineals, and the dancers have their toes pointed and externally rotated. So it does actually compress the outside of the foot, but it gives this nice line that they like to see. And then you see the point on the bottom with the hyperextended, the plantar flexion, and the nice arch of the ankle and the feet. We call them banana feet. And then the hyperextended knees, that's the lines they like. not very biomechanically sound, but that's what the art selects for and trains for. So there is a lot of injury data on dancers, but not much really addressing the hypermobility as a causative factor. As I mentioned, it's a little tough to really measure that in a consistent way in these artists because they're all so extreme. So it is difficult to assess and study. We do see it, and we look at their biomechanics in clinic, and we try to address the hypermobility in the rehab process. And mainly that means you really look at the biomechanics and see why they're injured in one spot. Usually there's a weakness, an imbalance, and it's then stressing one part of the joint where they're hypermobile. And so we try to correct that and get them to change their patterns a little bit and to be strong enough to tolerate the demands. So as they correct, they have to then slowly increase their activity and strengthen as they go so they don't continue collapsing in their excessive positions as they go back and fatigue more in the higher impact aspects of dance. I was going to talk a little bit about life as a dancer. Dr. de Borja was talking about early specialization, and dance is one of those activities, sports, arts that definitely specializes early. Many ballet dancers start very young and continue with multiple hours, 20, 30 hours per week through grade school and high school, and at an early age turn professional or try to turn professional. And they go to ballet schools where they dance, for 5 to 8 hours a day and do school in the morning, and then become professionals early in their late teenage years, early in their young adult life, and they're dancing all day, every day. So initially they start in a school, like we have the San Francisco Ballet School, or any kind of small ballet schools where they go to school outside, and then they go to their dance school and they train. In late teens, they often will try to audition and join a company, and they usually join in the corps de ballet. And so they do many of the main group roles in the performances, and they try to work their way up within the company to become a soloist, where they get to do some of the leading roles and become highlighted in the performances. Many of the soloists then, if they become very well known, can go and do guest performances around the world, or go and do extra performances, or become invited guests at other companies to do special performances or choreographies on their off time. So they may have 6 weeks off from their company in the year, but they'll spend that guesting and performing somewhere else in the world. So as far as injuries go, the corps de ballet, when they're trying to work their way up to a soloist, they tend to complain as little as possible. They don't want to take time off. They don't want to jeopardize their role in the company, and they're trying to work their way up. So they are at high risk for injuries, which we'll see in the injury data. The soloists are a little older and more mature and have already learned to negotiate with their bodies and learned what they need to do. And so they are a little better at taking care of themselves, managing their injuries. But we do start to see quite a few degenerative changes in the lower extremity in these artists at a very young age. And I'll show you a few pictures of those. Some injuries that were never complained about. We did an x-ray of a thoracic spine and found some rib fractures that no one ever heard of because they weren't complained about because the dancers didn't want to stop. So they very rarely complain if they want to be performing. It's a tough life. So different age and levels of dancers get different injuries. Mostly their overuse and weakness can be a factor. As with increased duration and intensity of training, they can be fatigued or weak, and that can lead to injuries. We do see the chronic conditions, a lot of ankle and toe, big toe degenerative changes and midfoot degenerative changes at early ages, 20s and 30s, that you would expect to see in later ages in a general population. So some common dance injuries that we see, something called ostrigonum or posterior impingement syndrome, which we'll talk about. Liz Frank injury, it can happen in dance. I think Jimmy Garoppolo had one. It's a traumatic sort of foot rotation injury where the midfoot becomes unstable. So it's often a traumatic injury, and we always sort of watch for that with imaging and physical exam and X-ray and MRI if we're worried about it, because it can lead to some instability in the midfoot, which of course is devastating to a dancer because they support their body weight up on that arch and through the midfoot. Anterior tibial stress fractures we'll talk about, very common in dance because of the load bearing through the front of the leg. Tarsal osteoarthritis, we see a lot of this. and manage a lot of this in young artists. And then Achilles and patellar tendinopathies, also see a lot of that, also known as jumper's knee. They jump a lot, particularly the males have big rolls where they do lots and lots of jumping. It's very common in the males to have patellar tendon issues and sometimes tearing. Flexor hallucis longus, FHL, it's a tendon that runs on the inside of the ankle to the big toe. I talked about this in the physical exam section, and the dancers alone get, because they roll up and down through their foot and they use their big toes, they get tendinitis along the course of that tendon and inflammation. It's very common to ballet. So a little bit about injury data. This is from Incidence and Prevalence of Musculoskeletal Injury in Ballet, a systemic review published in 2015. It looked at 1,365 amateur dancers, which were mean age of 16, and 900 professional ballet dancers, mean age of 27. So you can see they do dance through their 20s and 30s professionally. The injury incidence was found to be 1.06 in males and 1.46 in females per 1,000 hours of dance. And mostly was overuse, 3/4 overuse, more overuse in females, 64% versus 50% in males. And the lower extremity, of course, was the most common because we see a lot of hip and knee, but mainly foot and ankle. Lack of prevalence was noted for low back pain, painful snapping hip, and patellofemoral pain syndrome, but those were commonly seen as well. A little more injury data. This is a Spanish study that actually looked at all types of dancers, and they defined junior dancers as up to age 21. So again, developing their career into their 20s. Intermediate were sort of 20 to 30, and they defined senior dancers here as 32 and over. And those we know are going to have some wear and tear because that's getting up in age, and their bodies have been through this for years. So they found that the most common injuries reported in this study were patellofemoral pain, base of the second metatarsal stress fractures, which we'll discuss, and ostrigonum syndrome was more common in the younger junior professional dancers. And then in the older dancers, they found cartilage injuries in the knee and cervical disc disease. So interestingly enough, if you watch dance, you see there's a lot of neck movement. And the things that I did gymnastics Cirque du Soleil, there's a lot of neck stuff. And so the dancers actually have a lot of neck pain and cervical degenerative changes in young ages as well. I've mainly seen it in females in our practice. And so, as I mentioned, there were all types of dance included in this study, but the highest prevalence of injuries were found in the junior ballet dancers. So causes, so weakness with hypermobility. So this position here of this young dancer in first position, rolling in on her foot, so on your far left side of the screen, standing on 2 feet. She's rolling in on that. It's her right foot. So she's stressing, as you can see, the inside medial structure of her ankle and compressing the lateral side. So sometimes we even see lateral compression injuries from landing in these positions, and they're not pulled up enough and strong enough to control the way their foot lands. We see a lot of injuries in the younger ones when they're in growth spurts and they lose their core strength and they lose their center a little bit because they grow and they're a little bit all over the place for a while until they catch up with their strength. Also, dancers that start a little bit later in dance and they're trying to catch up and they're forcing their turnout to keep up with the ones that have been doing it since they were little and have this great turnout. I remember once I had a young male patient that started late. He had done some other sport and then found he loved dance, and he had a lot of injuries related to trying to really force his turnout and quickly gain his flexibility. So sometimes we see that. Also, there's these thing called summer intensives in dance, where a lot of the young dancers who are in their schools, they go off to a San Francisco Ballet School or a Boston or New York for a summer intensive where they train about 8 hours a day. And these are teenagers or preteens even sometimes. And they're not doing that much, normally in their life they're going to school and then dancing a few hours a day. And so they all get injured, not all, but there's a lot of injuries in these intensives. I used to work with the San Francisco Ballet School, and I'd see all these dancers coming in from other places in the country, and they weren't used to the style where there was a lot of turnout or whatever, and they sustained more injuries. Also the volume and the intensity. So in young dancers, sort of like 10, 12, preteen, we see a lot of hip flexor tendinitis. That's a very common one because they don't have their strength and stability from their glutes, and when they lift their leg, they tend to overgrip with their hip flexors, and they work incorrectly, and they get some irritations in their tendons. It's very common. We see a lot of Achilles tendinitis. Of course, they're turning out and jumping a lot, so that's a common injury. And then, as Dr. De Borja mentioned, the apophysitis injuries, which is the tendon attachment to the growth plate, that gets inflamed. That is diagnosed by age, common in certain age groups, Kalkaniel, Sievers, and then Sinding Larsson Johansson in the patella, a little bit older, Osgood Schlatters in the inferior, in the tibial tubercle, a little bit older. So those are common injuries as well because they occur in times of rapid growth and high activity. And of course, kids are dancing a lot in high activity. We see back pain, pars stress fractures from all the arching, and then we can see hip flexor injuries and strain there. So talk a little bit about the os trigonum, which is posterior impingement. And so this is a little bony protrusion at the back of the talus, and the talus is the arch of the ankle joint, so the ankle's a hinge joint that goes up and down, and at the back there's a little, sometimes an extra bone in 5 to 15% of the population where it sort of pinches out. So most people don't notice that unless you're a ballet dancer and you have it, and you're always up on your toes, and that part is getting impinged, as you can see in the x-ray there. We actually x-ray the dancers in releve or on releve or on point, to see if it's causing impingement. There's different sizes. Some can be big, some can be small. There can be some acute inflammation in the tissue around it, and so they can have tissue tenderness. So you want to delineate if it's, or differentiate if it's bony impingement and the bone is inflamed and you really just need to rest them, or if it's just soft tissue impingement. But we treat all of these with a reduced movement arc, so they don't go all the way up on their toe. They just stop short of the full releve, or we take them off point to stop that impingement for some time so it can rest and the inflammation can calm down. We do physical therapy to strengthen them and correct their alignment and make sure they're strong to control in that position. And we can do anti-inflammatories. We try to avoid cortisone injections because of tissue damage. Occasionally, this can be a surgical problem. It typically happens in the younger dancer's career in their teens, and they're really struggling. It can be career-ending because it's hard to recover from a surgery to really fully regain your motion. And so usually, mostly, we try to treat this non-surgically, and dancers in their 20s and 30s who have the problem have usually learned to manage it pretty well. So this is just a picture from an older textbook, Bruckner and Kahn, a sports medicine textbook, and it shows physical exam, so forced passive plantar flexion. So the top picture, you can see the examiner is forcing that heel up, and you just kind of jerk the foot a little bit into the forced plantar flexion. And if they have posterior impingement that's symptomatic, that will hurt them. So it's very specific. And then they also can be tender if you kind of palpate in behind the Achilles in the retrocalcaneal area. This shows him palpating the Achilles as well, and then the insertion of the Achilles. But it's that forced plantar flexion that elicits pain from posterior impingement syndrome. So that's a common dancer injury. You don't see it too many other places. I did see it in a long jumper this year randomly, but it's usually in dancers. So we'll move on and talk a little bit about pars interarticularis stress fractures, which I did speak about yesterday. Any of you who caught that will have heard some of this, and so we'll be really up to date on it. This accounts for almost half of lower back pain in adolescents. It's much less frequent in the non-athletic population, and it is very common in dancers. It presents as pain with back extension, sometimes pain with flexion if it's progressed and you have a bilateral and you have a spondylolisthesis, putting tension on the nerve roots. Physical exam, we talked about that today as well, that one-legged extension test where you lean them back on one side and extend them on each side to see if it's unilateral or bilateral. That reproduces pain. If you're doing x-rays, you want to get oblique views to look for this nice little Scotty dog. The arrow is pointing at his collar on his neck, and that is a fracture. So they shouldn't have a collar on their neck if you see that on x-ray, but you need those oblique views to see the fractures. Often the x-rays are normal. They don't have a defect or a fracture, but they have a stress reaction, so you're suspicious. You'd get an MRI. That would show the bone edema in the pars area, and often doesn't show the fracture. The x-ray can show the fracture, and sometimes we look at a thin slice CT scan, so selective in just in that area at L5. If you know they have a pars injury, you're not sure about the crack, you can order a limited thin slice CT scan just at that level, say it's L5, to reduce their radiation and just look at and see if there's a crack or not. So here we have an MRI with the red arrow pointing to the bone edema, which is a little bit of whiteness in that pars area. And then we have a CT scan showing the spondylitic defect and then the reactive sclerosis on the other side. So the defect is a little crack. The treatment for this, as we discussed, is rest. Sometimes we use the brace. That's a little controversial. If it's bilateral and they're sore, we put them in the brace. If it's unilateral and they're really sore, we put them in the brace. And that just helps them rest. The length can be 4 to 6 months, 3 to 6 months. It can take certainly a long time, particularly if they present a little bit late. We work on a lot of physical therapy, hamstring stretching, and core stabilization. And in dance, we let them move their leg once they're better, but they can't arch and do all these things, and then we slowly work them back when they're pain-free. Yeah. So talking a little bit about injuries in professional dancers, differences between males and females, overuse versus acute. Acute injuries do happen. We see a lot of ankle sprains, very common injury of all grades, and you usually don't take a whole long time to rehab, so they're trying to work back through them. Which it can be tricky because you don't want them to re-injure, and they have a lot of impact, and with instability that can cause a lot of persistent pain. So we try to get them to rehab and strengthen everything. We see shoulder injuries and particularly subluxations because they have some laxity. So often the males who are lifting the females will have shoulder issues or subluxations. You can see it in females as well, of course. We see muscle strains, knee injuries, contusions. Rarely we see concussions. I very rarely see concussions, but sometimes they collide or they hit their head on the floor, but certainly not like football or other sports like that. Overuse injuries are the most common, of course. We see a lot of stress fractures, the posterior ankle impingement. We see anterior ankle impingement as well, where they develop some bone spurs and thickening. They have trouble flexing down. That's from degenerative change and trauma. We see Achilles tendinosis, patellar tendinosis, patellofemoral pain, hip flexor issues, hip pain and labral tears, and then ankle DJD. So here's a little case about a dancer with hip pain. So this was a 24-year-old came in with some left anterior hip pain. It had been there for a few months. It was sore with passe, so when they stand on one leg and pull their other leg up in a turned out position, she had pain in the front of the hip with that position, she or he. And then with hip flexion, lifting the leg to over 90 degrees in the front or the side. Didn't seem to get better with a little bit of activity modification. They keep their legs low for a while, try to limit the time with it high, taking NSAIDs. So on exam, she was found to have glute weakness and a little bit of impingement signs with a little bit of pain on flexion, adduction, internal rotation, positive Fadir test, pain on Faber test, which stresses that anterior labrum. The pain was in the groin, not in the SI joint. So we did X-ray her and we did MRI her, and MRI was fairly classic for what we see in these dancers, which is why I use this case. But we did see a little aspherity of the femoral head-neck junction with a little cystic change. Of course, if your leg is always up here and it's banging, you can get some change in that head-neck junction as the femoral neck bangs up in the acetabulum. You can get labral tears from that, degenerative spurring and thickening, which this patient had. There was a partial tear at that junction, a chondrolabral junction where the labrum attaches to the acetabulum. However, those findings were seen on the other hip as well, where she didn't have pain. So those are common findings in dancers because of their activity with that leg being up all the time, and there's some wear in that part of the hip. So the question was that causing her pain or not? Because she had it on the other hip. So what else could it have been? She had a little bit of glute tendon irritation. We did note that she was weak on exam. She had a bit of mild bursitis on the MRI, but not clinically. So sometimes you see that too in these athletes, runners, triathletes who do a lot, dancers. You see some inflammation at the lateral hip and they don't actually have pain there. So you don't need to inject it if they don't have pain, just strengthen them. And then she had this mild dysplasia in her hips. And so clinically she had a little hip flexor irritation as well. There was nothing on the MRI. So we treated all that with physical therapy. And most of the time that works. This is a slide that Dr. Wong had as well, but this was just describes the hip dysplasia. So the red line, below the red line where the yellow arrow is showing some of the femoral head that is not fully covered by that socket. So that's a little bit of a shallow socket or mild dysplasia, which puts more wear on the structures in there, the labrum and the cartilage. But it allows you to get your leg way up high, and so you're really flexible. And if you dance, you get a little more wear in that area. So dancers do fine with this condition. Many of them have it, and we just have to back off and strengthen them. Occasionally we'll do a little hip injection if they're really flared up, but usually they respond well to physical therapy, rest, strengthening the glutes, correcting their mechanics, some NSAIDs. Mostly surgery is avoided. We don't want to do a hip surgery in a professional dancer. It'll be hard to get back in a long recovery. We do think that it's more common in the dancers, but hasn't been really well studied. So this dancer did well. Since writing this talk, it has come back, and there's been another little flare, but has improved. So it's not uncommon for this to happen, where they manage it, and then later it comes back, and then they manage it, and it's just part of their life. So another case, this is a female dancer presenting with vague anterior leg pain, despite backing off in jumps, so just jumping less, not as high, for several weeks before she presented to us. Pain was there in the morning when she got out of bed. It was worse after dancing. She had pain to be on point in point shoes and to work on point, and as well as with jumping. She had the pain a little before, didn't tell us about it. It got better when she took it easy for a bit, and then it seemed to come back this year as well. It felt tender to her. She wasn't sure if it had been swollen. We always ask about risk factors, so she did have regular menstrual cycles, and her weight had been stable. But she had been doing a lot more lately, a lot of rehearsals. She had a couple big roles with more jumps and was working really hard. In the performing season, they do rehearsals and class and shows, and so it's just a large volume. And she had been trying all the normal RICE price measures, and it didn't seem to be working. So physical exam for this, is that right? Yeah. You would look at the biomechanics. You have them hop. As we talked about in the physical exam, a pain to hop is worrisome for a stress injury. And sure enough, there was pain to hop. You always can screen for the lumbar spine. You look for swelling. You can often see a little swelling in the tibia or any other area where there's a stress injury, because you get some swelling around the bone. Check range of motion. Check very carefully for bony tenderness. In the tibia, you want to palpate up the front as well as in the posteromedial side. So these dancers get tibial cortex stress fractures, so you have to palpate on both different sides. You do muscle testing and check their neurologic function. So this person had pain to hop, pain to go up on being on point shoes and load through that front of the tibia, and was point tender right on that front of the tibia. There was a little bit of mild swelling over it as well, a little bit of a bump. You often feel a little bump because there's a bony reaction there. The initial x-ray showed a subtle lucency in the anterior tibia. And then the MRI showed a little focus of chronic stress reaction. So we'll talk about these. They're a little different from a normal stress reaction. There was no periosteal edema, so it had been there a long time. It was no longer inflamed and healing. It was just kind of stuck there. This hypo-intense focus of decreased bone density. So these actually resorb, and they stay walled off and resorbed, and they have trouble healing. The blood supply doesn't go in, and the bone doesn't turn over and build back up. And so they're very tough to heal. And this was, similar on the MRI, which didn't show much periosteal reaction. We did a CT scan, and we had the X-ray as well. Over time, we saw this hypodense area slowly fill in, but it took a very long time, about a year or longer. And we see many of these in these dancers, and they take a long time to heal. This is a nice picture of a CT scan. You can see that little hypodense region in the anterior cortex. So that is the front of their leg as the cortex points out, and there's a little gray lesion, and then on the other sequence with the marker, there's a little white lesion that's sort of walled off, and that causes pain when you load it. So this is a tibial stress fracture, the dreaded black line in the anterior cortex or tension side. The bony line is resorptive and indicative of non-union. They may persist for a long time in many populations. They're treated with an IM rod. The dancers really don't like to do that because it takes them out for so long. It's very invasive. Sometimes you can see multiple black lines. The diagnosis is similar to that of a stress fracture with this crescendo pain. It gets worse and worse over time, and as they act and are more active, there's increased risk of it if they're osteopenic, late age of menarche, history of other stress fractures, or have current amenorrhea. They typically have point tenderness and some thickening in the area. The x-ray may be normal or just show a little bit of callus or change focally. Bone scan can be positive, and we use MRIs to look for edema to see if they're still actively healing or if they're a little colder. It's going to take longer. The CT scan is best for looking at this. It can also rule out other things like osteoid osteoma or Ewing sarcoma, which can be found in this age group, and it should be on your differential for bone injuries, bone pain. So chronic tibial stress fractures, it's in the tension side, so it's the front of the bone, and when you're up on point and you're loading, it's pulling away, and so it's hard for these to heal. They're also common in basketball players, and those are treated with a bone stim and rest for 6 weeks, and if they don't get better, they get a rod after 6 months. This is common in the tension side of the tibia, about 2 to 4% of stress fractures. It's a poorly vascularized area. It can lead to non-union persistent pain. We can plate them or rod them surgically. They can have multiple dreaded black lines, and it was first described in 1956 in 5 ballet dancers. They did prolonged rest. One of them did progress to a comminuted fracture, didn't rest, and did a leap, and her bone cracked. In 1975, thought this was interesting, they found a ballet dancer describing shin splints and was found to have multiple diffuse cortical thickening and little fractures, transverse fractures, and was put in a wheelchair for 5 months, which wouldn't go over too well these days. But that dancer did get better. And eventually this dancer in this case did get better and is back pain-free, but it can take a couple years to fully be pain-free. So just to speak a little bit about bone stress, bone fatigue is a continuum from fatigue to stress reaction to a fracture in the bone. It's from overload activity, impact forces, pulling of the muscle on the bone, and increased osteoclastic to osteoblastic activity. So the osteoclasts resorb and the osteoblasts build bone, and if there's an imbalance, you get a weakness, and that progresses with load. You can then have a fracture. So risk factors, gait, mechanics, training loads and volumes, and then bone health, impact loading and the shape of the bone density. There's a variety of factors. Of course, training is the big one, volume, intensity increasing, and then duration of the strain cycle, so time, loading. And in our dancers, it's direct loading on point, direct loads that spot on the bone. Calcium can play a role if they're calcium poor or vitamin D deficient. That can play a role in bone metabolism. So most fractures, stress fractures, respond to rest. You have to get off of them, reduce painful activity. You can do pain-free activity, whatever that is. It might be just swimming to start. It might not even be walking. If you have pain-free walking, you can then progress over time. So we give them a limited activity for a certain period of time and then slowly progress them back. We'll use a boot or crutches if they have pain to walk. Start them in the pool, on a bike, and then rehabbing and strengthening. It's interesting because they get better clinically before they get better on imaging, and so I don't necessarily re-image stress fractures. Certain high-risk ones I might, but I wait 4 months before I would re-MRI it because it takes about 4 months for the MRI findings to start to resolve, and that's as long as they have no pain. If they still have pain, they could still have findings on imaging too. So it's not a helpful measure to follow them unless they're sort of a high-risk one you want to check. This is a little a table from an older textbook that shows just some of the higher risk stress fractures that do require a little more aggressive rest with non-weight bearing or crutches. As you can tell, it's old because I think they said bed rest for the femoral neck, bed rest for 1 week. But if you have a tension side femoral neck stress fracture on the top part, that needs surgery. The inferior side, the compression side, which runners get and dancers get, those are more common. Those you need crutches, so get off of them. And non-weight bearing, I don't think I'd do bed rest. But these are some of the higher risk injuries: talus, navicular, metatarsal, the base of the second sesamoid bone in the foot, the fifth metatarsal, and that anterior tibial cortex, which can take a long time. So there are high-risk and low-risk stress fractures. Some that are favorable to healing are usually on the compressive side and respond well to rest. These include the femoral shaft, the posteromedial tibia, which is the more common sort of running stress fracture, though they still take a while, rib stress fractures, ulnar shaft, and most of the metatarsals, except the base of the second, which I'll show you a picture of. High-risk stress fractures are things like the tension side of the femoral neck, even the inferior side we're careful with, anterior tibial cortex stress fractures. The medial malleolus is a tough one to heal. Sesamoids are very tough, and the tarsal navicular, which is shown in this picture here. I had this one in gymnastics, had to retire because of a tarsal navicular non-union and missed the Olympics, went into diving after that because it was much easier. And I had a non-union. So you can have these non-unions where you still see the fracture on the CT scan, but you get a fibrous union. And so they do heal and you move on with your life without pain, but sometimes they don't tolerate that intense sport pounding, depending on what level you're at. This is a really nice picture sadly, of a dancer with a base of second metatarsal stress fracture. This is what can happen to these stress fractures if not treated. And I used to always wonder, like, what happens if we don't treat these? Because sometimes they don't come in. This is what happens. They progress to this sort of fracture that probably isn't going to heal and causes pain on and off, and who knows how much pain, because there's high pain tolerances out there. But if you don't treat these, they can crack off, and the ligament has pulled it, and it's just not really healing. It's probably been like that for several years. So in summary, injuries are common in dancers, and the pre-professionals seem most at risk. Overuse injuries are more common than acute, more commonly in females. Ballet selects for hypermobility, and some maneuvers, such as turnout, put more stress on anatomic structures over time, such as hips and ankles, and that can lead to injury. Weakness is seen in young dancers at times of growth or increased training seems to lead to overuse injuries, and hypermobility can play a role in those injuries as well, particularly with weaknesses or overuse and not controlling the way the joint is moving. Stress fractures require a period of rest and then gradual return to activity once pain-free, with a strict rehabilitation and re-strengthening to address the weaknesses, imbalances, and the training errors or the nutrition errors or metabolic errors that might lead to those stress injuries. Ignoring pain and high-risk stress fractures can lead to chronic injury. So we're going to do a little quiz, a little tricky question. So all of the following are common dancer injuries, except ostrigonum, patellofemoral pain syndrome, flexor hallucis longus tendinitis, hip pain from labral tears secondary to hip dysplasia, anterior tibial cortex stress fractures, concussion, base of second metatarsal stress fractures, or hip flexor tendinitis. What do you think? Yeah, good. Okay, excellent. You passed. Any questions? So the question is relating to mental health in these dancers. It's a good question. Do we see depression, anxiety, things like that? So the dancers come from a vast cultural background, especially in the professional companies. And so they bring with them their own cultural preferences. They're away from home. I would say that that injury is a risk factor for mental health because that's their profession and they need their bodies. And so I think that the mental health can suffer if they're injured for a longer period or they have to have surgery or something like that. But otherwise, I wouldn't say it's higher than the normal population.
Hello.
Hi.
The question is there any specific age group wherein you need to give up ballet dancing due to normal aging?
Sorry, can you repeat it? Any specific age group that?
You need to just give up ballet dancing.
Oh, they need to give it up. Maybe 40s? No. No, I think a lot of it depends on how far they go and how successful they are and how much they pound on their bodies and also their genetics and mechanics. So, you have a little dysplastic hip that you dance on for 20 years and it starts to wear out. Versus, we do see these ankle arthritis conditions at young ages, and they surprisingly can go a long way too. But I think it's really dictated by their how good they are and how far they can go professionally. I think it is important, in dancers growing up to do other things because some of them fizzle out or aren't successful or don't have the right body type in their teenage years, and that can lead to depression and mental stress, as in any sport. If that's all they've done and that's all they know, it's their identity. So I think it's important to keep them varied for a while and make sure they think about other things and academics and school. And it's actually interesting because we've had, dancers that had education opportunities that chose to stay in dance. And so, that's their career path and that's what they're choosing. And so they'll follow that as long as they can. And sometimes injury will dictate when they end. Do we see osteonecrosis of the hip in the dancers? I haven't. It's not common, luckily. So, no, I would say not commonly. Mainly because they're young, right? And hopefully we don't use too many steroids to give it to them.
How do you make the decision whether to brace someone who's had a spondy fracture that's complete, not complete, or displaced, like a spondylolisthesis? Great
question. So if they have a spondylolisthesis due to bilateral pars fracture, they definitely get a brace. in my mind, especially if it's acute. They can heal. You have a healing phase where it's acute and there's blood flow in there, and you want to, isolate them as much as possible, almost like a cast, which you can't put on. It becomes less clear after that, and the studies are controversial, whether you do or you don't. Personally, if they're bilateral, I tend to brace them, for 4 to 6 weeks, especially if they're very acute. If they're unilateral, it's a little, for me, I'm a little bit more based on how sore they are. If they can sort of do daily activities without pain, then I tend to not. If they're still in quite a bit of pain, I'll put them in a brace just to calm their pain down. And that might be a shorter time. Also, depending on how hot it is on the MRI, if it seems really lots of edema, probably a brace is going to help. If it's kind of mild, they're not that sore, I might skip it and just do physical therapy. We used to get spinal bone stimulators too. They're hard to get now, but I used to get a lot of those because I see a lot. And you'd have bone stimulators that could help speed up the healing. They're hard to get now through insurance, but for a while they were quite popular.
Kristin, what kind of injuries do you see in Cirque du Soleil?
Good question. I was part of a big study that tried to document some injuries in circus artists as well. That was published 5 or 10 years ago now. We see a lot of overuse injuries, similar patterns, I believe female more than males. So the baseline is some overuse injuries. So all extremities, lower, upper extremities, shoulders, depending on what they do. The thing with Cirque du Soleil is a lot of us came from elite gymnastics, which is pretty hard on your body. So there's a little carryover of, labral injuries and shoulders and hips from gymnastics or whatever other sport they were doing before Cirque. So there's the overuse injuries, the chronic ankle pain from injuries. We see a lot of acute things like weird like subscap tears or ACL tears or rotator cuff tears. You do see some extreme acute injuries. You see some concussions sometimes from collisions or bad ankle sprains. So the acute ones can be bad. Collarbone fracture, from falls, and then the sort of the underlying acute injuries, or chronic injuries, sorry.